Okay, so a little bit of history. The first test tube baby was born in England in 1978. That's Louise Brown. You might have heard of her. She actually has her own child now who's 2 years old. 1981, first IVF done in US. It started with procedures called GIFT and ZIFT. And that is gamete intrafallopian transfer and zygote intrafallopian transfer. So when IVF was first started, the thought was, okay, well, eggs and sperm fertilize in the fallopian tube. So we should take out eggs and sperm and put them in the fallopian tube because that's where they should be. That's where fertilization happens. So eggs would be taken out, sperm would, be taken out, and then a woman would go through a surgical procedure to have these gametes put back into her fallopian tube. Or a zygote, or they'd have the eggs and sperm fertilized outside the body and then put the zygote back into the fallopian tube. So that's how it all started. And now we don't do that anymore. Now we grow them in the lab for a few days and then we put them back into the uterus. And so last year more than 98% of IVF was done by transferring an embryo to someone's uterus. Yeah, Daisy.
Are there ever people? Yeah, is it on? Yeah. Okay. Are there ever people who want twins who, when you do the fertilization of the eggs with sperm, they would rather, if 2 sperm fertilize 1 egg or whatever, would rather have twins than
there are definitely people who want twins.
Do you do that?
You can't do that. We have high twin rates. So I always tell them, there's a good chance you will. But no, there's no really way where you can make a decision that someone's going to have twins because it has to do with putting a certain number of embryos into the uterus and it's really how many embryos are going to implant and you can't know.
Didn't you say there was one treatment where you take 1 sperm and put it into the egg?
Yes.
Couldn't you take 2 sperm and put it into the egg?
No, because this is the interesting part about this. When you talk about twins, it's not from that. When you talk about twins, it's from 1 sperm going into an egg. That's how normal fertilization occurs. So normal fertilization is not going to occur from 2 sperm going into an egg. It's actually going to be an abnormal fertilization, and it won't turn into a baby. It's going to be 1 sperm going into an egg, fertilization occurring, and then at some point during those first few days to a week, that this embryo then splits, okay? Or what happens most of the time with in vitro fertilization is we're putting in more than 1 embryo. We're putting in 2 embryos into someone's uterus and they're both implanting. So there's 2 ways it can happen. It can just be from absolutely 2 separate fertilizations that occurred. That can happen naturally too. Woman could release 2 eggs, they both get fertilized, they both implant. Or a woman releases 1 egg, it gets together with the sperm, and as it's growing, it divides. Yeah. Any other? Okay. So this is just a little more detail about IVF. We give women, like I said, FSH injections to make multiple eggs grow in their ovaries. We watch the eggs grow on ultrasound. Actually, I think that's, hold on a second. I'm going to forget. I think that's coming up. Okay, let's just talk about statistics a little bit. In 2005, 422 programs offered IVF. ART is assisted reproductive technology, so basically IVF. Over 134,000 cycles of assisted reproductive technology. Over 9,000 donor egg cycles, and over about 39,000 deliveries. And then you can see this with 52,000 babies being born. So there's a lot of multiple pregnancies going on from this kind of treatment. We talked about, who might need IVF. Somebody who's failed these other insemination treatments and things we've done. Someone whose tubes are closed. Somebody maybe with, not a lot of sperm or good moving sperm. No uterus. They carry a genetic disease. Gender selection. Someone who's newly diagnosed with cancer, maybe. I see patients like that. They're just newly diagnosed with breast cancer. They're 33 years old. Before their chemotherapy and radiation, they want their eggs taken out, make embryos, freeze the embryos, so later on they can have a baby in case their ovaries don't do well with the chemo and radiation. Yeah?
In the case of a woman with an absent uterus,
yeah.
Into where does the vaginal canal and cervix open? Just the body cavity?
No, so if somebody has an absent uterus from, what I told you about, where they're born without their uterus, that's called a Müllerian defect. It's called the syndrome. It's called Meyer-Rokitansky-Kuster-Hauser syndrome. Okay, nothing in the middle formed, but the ovaries formed because they come from different places. So those people actually didn't have a Müllerian duct formation. So they didn't make a uterus, they didn't make a cervix, and they didn't make the top of their vagina. But they made the bottom of their vagina. So they have about a third of a vagina. So they look totally normal. If someone was to do an exam on them, you know, they would think they're absolutely, there's nothing wrong. But then they don't have period, right? So people like that, that they're not gonna have a cervix, they're not gonna have a top of a vagina. People like that need to typically make a vagina in their lifetime, right? So that they can have like a normal sexual life. So, and the way that people usually do that, there's two ways to do it. One is with a surgical procedure, and that's not usually recommended actually, that's what used to be done. And the other is with something that's called a dilation technique, where they use these dilators that are on kind of the top of a bike seat, and the dilators get bigger and longer, and they basically make a vagina when they're ready to have sex. Yeah. Yeah?
I took a class that talked a lot about those and other intersex type conditions.
Yes.
And there's a piece written by a person with that disorder called the missing vagina monologue.
Yeah, yeah.
And it's actually, I've heard that's an incredibly uncomfortable
Right.
experience.
Yeah, it can be. It has to be really gradual, and someone has to be really motivated to do it. The thing is, once the vagina is formed, if someone has sex regularly, it stays there. It's, you know, it's there. But you're right. You're right. Okay, so this is how we do IVF. A woman gets FSH injections, so that same hormone injected into her body every day for about 10 days. And this is an ovary that is hyperstimulated. It's getting a lot of FSH. And each of these little black circles that grows in the ovary is a follicle, a fluid collection that surrounds an egg. So normally where a woman would have one of these grow in a menstrual cycle, see now this woman's having lots of these grow. And this is how I monitor these patients doing IVF, as I do ultrasounds every other day, every 3 days, and watch these eggs grow, or watch these fluid collections grow. When the fluid collections get to the right size, see how these are a lot bigger? When they get to the right size, they should have mature eggs inside of them. So then I do an egg retrieval procedure. An egg retrieval is done under ultrasound guidance, and then we look at the eggs. This is actually just a nice microscope picture. This is a nice egg. This is a good egg. This is not a good egg. This is a bad egg. And it's bad just because of certain things, and it's grainy, it's dark. There's certain characteristics in an egg that makes us think that it's not healthy. So once the egg comes out, then we can fertilize it in two different ways. We can just put eggs and sperm together in the dish and let them fertilize on their own. That's called IVF. We can do IVF with ICSI. That's where we take single sperm and inject a single sperm into each egg. We do that procedure the same day that the egg retrieval is done. So eggs come out within the first couple of hours of them being out, they're fertilized with a sperm. And then see these two little things right here? These are two pronuclei. So this means that fertilization occurred, two pronuclei. One, these are from the man from the woman. And so this is what we want to see on day 1 after egg retrieval, that we call the patients and we say, okay, of the 10 eggs that we got, we had 7 that fertilized normally, so we have 7 embryos. We let the egg continue to grow in the lab, the embryo, I'm sorry. And this is an embryo on day 3. So what it's done typically now is it's gone from 2 cells to 4 cells to 8 cells. So usually by day 3, we see about a 8-cell embryo. This is a really nice embryo. It's got really nice clear blastomeres on it. And this is a yucky embryo. This is a day 3 embryo with about 3 cells there, 3 blastomeres, and then all of this junk inside. It's called fragmentation. We grade embryos, okay? So when the person comes to have their embryo transfer, we're gonna tell them about their embryos. They got a good grade or they got a bad grade. And this one got a really nice grade. This got a grade 4. 4 is the best grade you can get, it's like A, okay? And we grade it based on the size and symmetry of the cells and then fragmentation. We're looking, is there all that debris inside here? No, this one's really clear. And then this one would be a 3-cell grade 1. It gets the bad grade. And usually these ones that are really bad looking like this don't implant. This is a day 5 embryo. So if we keep growing it, so we go to day 4, which is a morula, we go to day 5, which is a blastocyst, you can see how different it looks. So all those cells become just multiple cells now, and then they start to compact and they start to change, and they form this cavity, and that's what makes it a blastocyst, is this cavity right here. This is actually a really nice looking blastocyst. So we can do a transfer on this day, or we can do a transfer back on day 3. Those are the 2 days that we put embryos back inside.
Excuse me. Notice the inner, can you go back?
Yeah.
Notice the inner cell mass, and that's where they'd get the embryonic stem cells from, if someone donated that embryo. And they would take that inner cell mass and make human embryonic stem cells from that embryo.
After this stage, then this embryo inside has to hatch out of its shell in order to implant on the uterine wall, and this is a hatching blastocyst. So see, it's coming out here. And so on day 3 or day 5, that's when we put embryos back in somebody's uterus. And this is a picture of basically a uterus on the day of embryo transfer. This is the cervix up here. This line that goes, see this little line that goes into this area right here? This is the canal that goes from the cervix up into the uterine cavity. This is muscle of the uterus, and this is where an embryo will implant. It's right here. It's called the endometrium. So what we do on the day of embryo transfer, take the embryos in a little catheter, put the catheter, while we're looking with ultrasound, put the catheter through the cervix. We watch it go up like this. We watch the catheter tip go to right about here. And then once it's there, we push the embryos in. So we push them in with a little plunger on a syringe. We watch them go into this area, and then we take the catheter out. Once we take the catheter out, we go back to the lab. We look under the microscope. We make sure that the embryos came out. We want to make sure they didn't stay in the lab, stuck in the catheter, and they didn't really go in. This is just another picture of a transfer. There's other special techniques we can do with IVF. And most people that do IVF just have sort of basic IVF. Take the eggs out the sperm, we let them fertilize the way that they're going to, we do a transfer. Other people might have special procedures done like assisted hatching. So remember how the embryo has to hatch out? We sometimes do assisted hatching where we do it with a laser, and we make a little weak spot in the shell of the embryo to try to help it hatch. We do that for people sometimes who've had multiple failed IVF cycles, where we think that they have nice embryos, we don't know why they're not implanting. We do it for people who look like they've got a really thick shell surrounding the embryo. So that's one thing. We don't do it for everybody because it does have a risk that goes along with it, and the risk is something called monozygotic twinning. And monozygotic twinning is where you have twins that are in the same sac. So they don't have anything separating them, no membrane separating them. It's a dangerous kind of a pregnancy because they can just wrap all around each other with their cords and that type of thing. Slightly increased risk of that. That's why we don't do it for everybody unless we think they need it. This is an empty shell, basically an empty zona after we've done our assisted hatching and the embryo's hatched out of there. Something else that we can do is ICSI. That's intracytoplasmic sperm injection. This is a picture of an egg, little pipelle holding it right here. This is a needle, and this is a sperm. So you need one sperm when you do this, and we're going to take this needle and put it through this eggshell, like that, and then we're going to, and that's really normal that the eggshell will go in like that, the zona, and then the needle will go all the way through, and then the sperm will be just deposited right here inside the egg. Where's that little picture? Is it coming up? Okay. Okay, so here another question. So what are the risks of IVF? Bleeding requiring a blood transfusion, pelvic infection, increased risk of congenital anomalies, so a baby born with a birth defect, multiple pregnancies, or all of the above. Okay, so most of you said all of the above, and some people said multiple pregnancies. Actually, all of the above. So when people go through in vitro fertilization, I always talk to them about the risks. You have a risk of having bleeding at egg retrieval. You could have enough bleeding that you'd need a blood transfusion. Less than 1% chance of that happening. Could get a pelvic infection because I'm taking a needle that's going into your ovary. There is an increased risk of congenital anomalies with IVF. So there's about 2 to 3% chance in general of having a baby with a congenital anomaly. And with IVF, it's about 4 to 5% chance of having a baby with something wrong with it when it's born. Okay, this is sort of good for this media right now. So how many embryos are recommended to transfer into a 42-year-old woman's uterus after she has IVF done? Okay, so most people said 4. That's pretty close. So it's actually the recommended number is 5. So when someone's 41 or older, the recommended number of embryos to transfer is 5. And here are the recommendations. These are recommendations from the American Society of Reproductive Medicine. And if you're less than 30, if a woman is less than 35, the recommendation is 2. 35 to 37, 2 to 3. 38 to 40, 3 to 4. And more than 40, actually it's more than 41, 5. Yeah.
So the questions were bound to come up, but in the case of Nadia Solomon, who I believe it was 7 that were implanted, or maybe it was 6.
They say 6.
And 2 of them became a set of twins. I believe, from what I read, she's nowhere near 40.
She's
so
33.
Was that just a judgment call in the case of the doctor to put in 6, and it just so happened that she refused to terminate any of the pregnancies?
Yeah, it's a good question. I mean, if you just look at it just from this, you would say, okay, she's had babies before with IVF. It seems like from hearing her story, at least the only way that she could get pregnant was with IVF, probably because of her tubes being blocked. She has had 6 babies with IVF. She has had twins with IVF before. She's 33, so she's kind of like fertile infertile. And so the people would say, my gosh, you should be putting in 2 embryos each time. But we don't really know the whole story. That's the problem. We don't really know the whole story. She said that in 2 previous attempts that each time 6 embryos were put in and had no pregnancy. And so the thought would be, well, if you put in 6 and no pregnancy and 6 and no pregnancy, and you can be pretty safe putting in 6, but then you get 8. And so, that's the problem here. And I don't know, because I don't really know. I don't know how to comment on it because I don't know all the facts of the story. But typically, we wouldn't put in 6 in a 33-year-old person. Yeah.
So she had like 2 embryos that split into twins.
I mean, that's what,
Is that, no, but I'm just, so is that one of the things that, I mean, those are like identical twins, right? So is that like a higher risk with IVF?
No, and that's what is so sort of really amazing about this case, right? Because we will occasionally, I would say rarely put in 2 embryos and have 3 babies. Rare. And we have a really big practice, and when that happens, we kind of are like talking to each other like, oh my gosh, I put in 2 embryos and there's 3, sacs. Because it just doesn't happen very often at all. And so the fact that you put in 6 and get 8 is like that much more kind of, statistically rare. It's very rare. So I don't know. We don't really know. And she's saying who knows? Were there really 8 put in, or was it really 6 and they split? It could happen, but it'd be very rare for that to happen. And like I said, see the bottom part here, with patients who've had 2 or more failed IVF cycles, a poor prognosis, you might decide that you need to put in more embryos. And we have definitely had cases where we've put in a lot of embryos, but a person has a history where you're just slowly becoming more aggressive and more aggressive. And usually you'll end up with 1, even when you put in a lot in people like that. But sometimes I have had couples where I put in 2, nothing. I put in 2, nothing. We decide to be more aggressive, we put in 3, we get triplets. So it happens, then you're like, oh, yeah. So that kind of stuff happens. Okay, so let's say that you go through this IVF cycle and like that, somebody had 10 eggs come out, we had 7 embryos fertilized normally, we had 5 of them grow really nicely, and we decide we're gonna put in 2. So we have 3 really nice embryos left over. We can freeze them if we want to. Why would we freeze them? We could freeze them so if they did not have a pregnancy in that cycle, they wouldn't have to go through all of that again. They wouldn't have to go through growing eggs and retrieving eggs and all of that. What we could do is just prepare the uterus, thaw embryos, and put embryos back in the uterus. Or if they got pregnant right away, and let's say 2-3 years, they come back and say, you know what, we want to have another baby. They don't have to go through all that again. Thaw out the embryos and do another transfer. So we freeze a lot of embryos. We have tons of frozen embryos. There's so many frozen embryos in this world. And because of this, there's become this really big kind of debate about what do you do with these embryos, and it's called the disposition decision. It's like, what do you do when you're done with your childbearing and you have embryos left over? And what you can do is just keep freezing them just every year, and you pay a fee every year to freeze your embryos, and actually your fee goes up every year to freeze your embryos because it tries to encourage people to actually do something with their embryos. But there are people, and I have a good friend who had IVF and has 3 children, and they have 7 embryos frozen for years. Their youngest kids are 10. And they just, for religious, moral, reason, they can't do any of these things. I can't donate them. I can't give them away. I want someone else to have my kids. I can't throw them away. And so they just freeze them every year. But the options are just keep freezing them. You could donate them for research. You could donate them for research, for example, like stem cell research. You could donate to us to do research on them. We could practice techniques and things we need to do, teach people how to do ICSI, things like that. You could do embryo adoptions. So you could actually give your embryos to someone else to use them. Or you can discard them. We can just thaw them for you. So next question is, what would you do with your frozen embryos? Okay, donate them. Most people would donate them. Nobody would discard them. 7%, so 2 people said they would donate them to other person for adoption, and someone would keep, okay. So that's good. So you guys would, I mean, that's nice. You would donate them so we could do some research on them. Yeah.
What would, just a sec, Casey. What would you do, Dora?
I said that I'd donate them for research.
Faria?
I said D.
D? You discard?
Discard
Yeah.
them.
What about you, Ryan? Do you have a question?
I actually do. I was wondering if implantation rates were affected with the age of the frozen embryos.
That's a good question. So frozen embryos are, a frozen embryo transfer has a lower pregnancy rate per cycle than a fresh transfer. So it's about a 15% lower pregnancy rate per transfer once they're frozen. But frozen embryos, it's kind of nice. Frozen embryo success rates are always based on the age at which the woman was when they were frozen. So if you freeze your embryos when you're 33 years old and you do your embryo transfer when you're 40, you still have the same frozen embryo transfer pregnancy rate as a 33-year-old.
Is it possible to list yourself, like you're an organ donor? Could you list yourself to also be like an embryo donor in case you got in a car accident and you want your embryos donated to research?
So this is interesting. So one of the things that people have to sign when they do IVF with us is they have to sign contracts, a lot of consents and contracts. And one of them is, who is the custodian of the embryos? Okay? Because most people doing this are couples. And we have to only have one of them chosen as the custodian of the embryos in case of death, divorce, etc. So and this has happened, couples get divorced and now what are you going to do with the embryos? She might want to use her embryos and have another pregnancy and say, I don't want you to have another pregnancy, that's like my sperm. But they have to pick a person. So one of them has to be responsible for that. So if one of them dies, and that type of thing, and so it could be one of them, it could be someone else that is sort of like their legal guardian of their embryos. And that person would be the person to make the decision.
Could you pass them on in a will? I want to give my embryos to...
Yeah. Yeah. Okay. Okay. So these are success rates for IVF. These are 2005 success rates. And this is from the Society of Assisted Reproductive Technologies. And so basically, every center gives all their data to this SART committee. And you have to give it yearly, and there's a deadline. And it talks about how many cycles you did, how many cycles you canceled, how many embryos you put in on each cycle, and then they get statistics. And these are statistics for all the centers that report to SART. These are our statistics for 2005 from our center. But you can see that pregnancy rates decline with age. So the highest pregnancy rates for someone less than 35. And actually this year, our pregnancy rate's 50% for this. And then it goes down, 30%, 20%, about 10%. The highest pregnancy rates for donor egg IVF, somebody using a donor egg, 60% per cycle. And then multiple rates. And these are old, but it's the same. The singleton rate's about 65%, twins over 30%, triplets about 4%, and then higher order babies about 0.2%. Okay, so once we do our embryo transfer, 12 days after embryo transfer, we check a pregnancy test. 2 weeks after that, if someone's pregnant, we do our first ultrasound. This is just an example of one baby. This is its head, and this is its body. This is its little yolk sac. That's the thing that's nourishing it until you get a placenta. These are twins. See, these little twins are in the same sac. Little heads, bodies, arms. See little arm buds, little leg buds down here. And these are twins in 2 separate sacs. This is usually what we see. And these are triplets. One there, and one there. You can imagine what 8 would look like in there. It'd be like, you'd want to faint. So multiple pregnancies is a really big deal. And there are people, and you probably have read some of this with this recent case that came up with the octuplets, of where one of the doctors said, you know, to me, it's a failure if I have a triplet pregnancy or more. It's not a successful IVF cycle. And I think a lot of people feel that way. Twin pregnancies, you know, twin pregnancies do pretty well, but there are definitely more complications the more babies that you have. There's complications for the mom. The mom has an increased risk of having diabetes in pregnancy. She has an increased risk of having something called preeclampsia in pregnancy, which is very serious, also called toxemia. Babies, complications. Babies are almost always born early if there are multiple. Twins are typically born on average at about 36 weeks of pregnancy. Triplets, about 32 to 33 weeks of pregnancy, and it gets lower and lower from there. And that's 40 weeks is normal. Complications, fetal, so they can be born early, they can have long-term complications. That's, you know, one of the most significant things, is they might have something wrong with them the rest of their life. Cost of keeping them in the intensive care unit, and then the long-term cost of health problems. And even if they're all healthy, it's just the cost of having, you know, that many kids. And then the selective reduction. This is something that we do offer to people if they have a higher order multiple pregnancy, which is considered a triplet or more, that somebody can selectively reduce a pregnancy. Some people are very opposed to this. They would never do it. Other people say, yes, I would definitely do that if I had a triplet or more. And a selective reduction is something that takes place at about 11 to 12 weeks of pregnancy. So it's basically somebody, let's say, who has a triplet pregnancy, you watch, the reason it's not done earlier than that is because about 25% of multiple pregnancies will reduce themselves naturally in the first trimester. So you'll start out as a triplet, you know, about 8 weeks of pregnancy, you'll see one of them stop, and the other 2 will grow. And so we want to see what's going to happen first, because your body's obviously going to select the best one, because it stopped growing for a reason. If people make it through that point, though, where you would expect a pregnancy to be reduced naturally and they still want to reduce, they can at about 12 weeks of pregnancy. And then we could do a single embryo transfer. You know, you don't hear a lot about people doing single embryo transfers here, but it's done actually a lot in Europe, where they'll just put back one embryo. Then the chance of having a twin pregnancy is very small, unless it just splits on its own like it would naturally. Just has a lower success rate. That's the thing. Costs. An IVF cycle is about $10,000 to $15,000. That's including all of the visits, egg retrieval, medications. If we add things like assisted hatching or ICSI or freezing, you know, it becomes more expensive. If you use an egg donor, you add at least $5,000 to this cost. If you add a surrogate, then you add at least $10,000 to $15,000 more to this. So it's expensive to do it. And then we can talk about egg donation. That's a big thing. So would you consider being an egg or a sperm donor? Anonymous? Anonymous. Okay, so 55% said yes, they would consider, and 45% said no. How about someone who said no? Do you want to comment on that? Why no?
Who said no? Dora?
I said no because I don't want anyone else to have my kid, I guess.
Okay.
Faria?
I said no too.
Same reason?
Yeah.
Mm-hmm.
Don't feel comfortable.
Right.
Who
So
said
don't
yes?
want someone out there raising your child.
Albert, you
How
have a
about someone who
question?
said yes? Mm-hmm.
Ben?
I don't know. Sure, why not?
Okay. Can make $100. Okay. Huh? I got to keep moving. Okay. Yes.
If you donated your egg, or if I donated my egg, could I make a request? Like, I want the family to be like a healthy family. I don't know. Like.
Yeah, it's a good question. I'm sure somebody could make a request. Let's say that they had some requests like, I want the family to be a married man and woman, or maybe something like that. You could do that. Mm-hmm. But, you know, I mean, I think in general, most egg donors are just willing to donate their egg to somebody who needs their egg. Mm-hmm. Okay, and then our next one is, have you ever been an egg or sperm donor? No. Okay. All right. Okay, so egg donation, basically it's just IVF for 2 people. You have a donor who goes through the injections and the egg retrieval, and then you have a recipient, and that's the person where the embryo goes back. Like I said, donor egg IVF cycles have the highest pregnancy rates of anything that we do. People who can be an egg donor, you're 21 to 35 years old. People will sometimes want a known egg donor rather than an anonymous egg donor, like a friend or a relative, and then in those cases, sometimes they will pick someone who's older. The reason that we typically ask for anonymous donors to be less than 35 is just that you're just more likely to have a pregnancy from that and a healthy egg that's retrieved. An FSH level in their blood less than 10, that's a good indication of ovarian reserve or egg health. A negative donor, that just basically means somebody who is negative for infectious diseases that we screen for, negative in a drug screen. They have a good health and genetic history. And then there are donors that are called proven donors and unproven donors. And a proven donor is someone who's donated their eggs before and someone's had a pregnancy. And some people will prefer to have a proven donor, and people pay more money to have a proven donor. And this is, these are pregnancy rates with women using their own eggs. And these are, age down here from 27 to 47. And then these are the same, age groups using donor eggs. So pretty much your pregnancy rate stays the same if you use a donor egg. Doesn't matter what the age of the recipient is. Yeah.
Rose?
Does that increased success for donor eggs at older ages, does that just have to do with the relative age of the donor? Because you're hoping for 21 to 35-year-olds?
You mean, now this is the recipient.
No, that's what I'm saying, but the greater success for donor eggs,
yes,
is that most likely because the
donor's young. Yes. Because the donor's young. And usually in our office, actually, we recommend for people to have a donor who's 32 or younger, even because, yes, young eggs, success, they're just healthier eggs, typically not as many genetic abnormalities, and the pregnancy rates are high in people who are less than 35. Mm-hmm. Yeah. Maura?
Does it take into account the age of the person receiving the egg? The older they are,
no.
Wouldn't it create more of a health risk for the
Yes,
person?
we'll talk about that. That's what comes in. Pregnancy rates don't change. So you could be 44, you could be 54, you could be 64, but health risks. So, and that's coming up right now. Just a couple, articles that people have written about egg donation. I'm going to skip that one actually. Like this one where a fashion photographer had begun offering up models as egg donors to the highest bidders. Would-be parents will pay up to $150,000 of hopes of having a beautiful child. You've probably seen these ads, in the Bruin and stuff. Have you? We want, a UCLA student with a GPA like this and this and this. Most people don't really look for that. Most people are just looking for somebody who's kind of like them. Most people are looking for somebody that's similar to them. Okay, so with egg donors, you can either, if you choose to use an egg donor, it can be someone who's known to you or someone who's anonymous. Probably 95% or more of people use an anonymous egg donor. How many times can someone donate? The recommendation is for people not really to donate more than 5 or 6 times, and this has to do with just population genetic, what's the likelihood of this baby and this person meeting each other and growing up and being related, So if you look at that, it's 5 or 6 typically. That's pretty. There's still just a very low chance of people meeting and maybe wanting to get married someday from the same egg. How old is too old for a recipient? So that's what you were asking about. At USC, they've actually done a study on recipients of donor eggs, and the mean age of these women was about 53 years old. There were 77 recipients of egg donation. Of the 77 women, about 55% of them had live births, and there were 45 deliveries and 42 women, which means to me that 3 of these people probably had a second pregnancy from the same donor eggs that were frozen. Because even if it's a twin, it's just considered one delivery. And what they found is that people had increased health risks in pregnancy. And so preeclampsia is one of the things I talked to you about. Just background incidence of preeclampsia is 3 to 10%. And preeclampsia is something that a woman gets in the 3rd trimester of pregnancy where her blood pressure shoots up really high people start to get really swollen, and it's called preeclampsia because eclampsia is seizures. If it's not treated and treatment is delivery of the baby, women can start having seizures. It's very serious, and normally we'll see it about 3 to 10%. With these 53-year-old women, it's 35% chance of preeclampsia. Gestational diabetes, usually that's just developing diabetes in pregnancy. It doesn't mean that you have it after pregnancy. It happens about 5% of the time. People have to be on insulin injections. Babies can grow really big when a mom has gestational diabetes. It's 20% in the women that are in their 50s. So, you know, how old is too old? That's kind of the question. And there's no laws or anything about this. The oldest person, I believe, that has delivered is 64. From this, there have been like 2 64-year-old women. One when I was doing my residency who actually delivered at the hospital that I worked at, and who said she was 54 when she went through it, but she was really sick. You know, when she started having her prenatal care, she said, oh, I should probably tell you I'm 64. And another woman recently, I think, who was 64 and had twins, single woman, twins. So there are really increased risks, and of course, anybody who wants to use an egg donor, I typically, who's over 45, I talk to them about these risks. We do screening tests before doing IVF, like EKGs and blood work, and have them see an internist and a perinatologist and all of that. Okay, and then we'll get to genetic testing. There's different kinds of testing: preconception, pre-implantation, prenatal, and postnatal. Preconception counseling. So I offer preconception screening to every single person that I see. So most people that see me, they're wanting to have a pregnancy. So it's a great time to be screened for all of these things that we should be screened for. And that's when people want to start taking prenatal vitamins before they have a pregnancy. They have to have folic acid in them, and folic acid significantly decreases the chances of having a baby with a spinal cord defect. Most women aren't taking prenatal vitamins before they get pregnant. So it's a good thing to take any time where you're like a reproductive age woman, is to take a prenatal vitamin every day. We want to make sure women are immune to rubella and varicella. Rubella is something that we all get as kids. We get a vaccination for it, but some people lose their immunity. If you get either of these viruses during pregnancy, it's really bad for a growing fetus. So we check people for them. If they're not immune, we give them vaccinations. We look to see what their blood type is. That's what this RH status is, if you're a positive or a negative blood type. People with a negative blood type need special type of treatment in pregnancy. We test them for HIV, for hepatitis, things that can be passed on to a fetus. We test them for cystic fibrosis, which is a really significant genetic disorder that has to be passed on from both parents. We test everyone for cystic fibrosis now, one of the people in the couple. And that's because 1 in 25 to 29 people carries the gene for a cystic fibrosis mutation. And then this is the new one that's just been added, is spinal muscular atrophy, which is almost as common as cystic fibrosis, and it ends up with babies who they die at about 3 years of age from significant spinal muscle atrophy, where the muscles just shrink. And so that one we're starting to test everybody for too. And then we can offer special tests to people. So there's certain groups that are more susceptible to having things like thalassemia, which is a blood disorder, or sickle cell anemia. Cystic fibrosis, like I said, about 1 in 25 to 29 people carry it. Ashkenazi Jewish population have a lot of these autosomal recessive disorders that are fairly common, and so we'll offer people testing for this panel. Okay, so that's basically the prenatal. So people can have those things done. If somebody finds out, for example, they're a cystic fibrosis carrier, and then we test their partner and they're a cystic fibrosis carrier, they're going to have a 25% chance of having a baby with cystic fibrosis. We could do IVF. We could screen embryos for cystic fibrosis and only put back non-affected embryos. Then prenatal testing. So this is when a woman is pregnant. What kind of things can we do to test? What kind of testing can we do when she's pregnant? We can do ultrasounds. The earliest ultrasounds and testing that we do now is between 10 to 13 weeks of gestation, and we do something called nuchal translucency screening. So it's actually looking at the neck of the baby, of the fetus. And these are examples. So this is a baby's little face, little profile right here with the nose and the mouth, forehead. And this right here is what's called the nuchal translucency. So it's the back of the neck, and there's this little skin fold. And this white, between these two white lines is what we're measuring. And this is very small. This line, see, it's bigger right here. And this one is very big. And this is associated with Down syndrome, these big nuchal translucencies. We also look at the nasal bone, presence or absence of a nasal bone. We put those two pieces of information together and then give somebody an adjusted risk for Down syndrome, which may either give them some, good news that they don't have as high a chance of Down syndrome as they thought they might based on their age, or that they really maybe should have more testing done. Everybody gets a second trimester ultrasound, which is a very detailed exam that looks for Down syndrome, looks for other trisomies, and a trisomy is when you have like an extra chromosome 15 or 16 or something like that. We look for heart, spine, kidney, brain, limb, cleft lips, palates, all those things. These are some examples of things that we would see. This is what's called an echogenic valve. This is basically the intestines inside of a baby that has a certain kind of brightness to it. It's associated with Down syndrome. This is a baby with a multicystic kidney. It's got all these little cysts, so it might have something called polycystic kidney disease. This little baby has a little cyst in its brain. This one's got 6 digits. Little hand right there. This is a huge cyst behind the baby's neck. We also offer blood testing during pregnancy. At 15 to 20 weeks, we do something called a quad screen. It's basically a screening test for spinal cord defects, Down syndrome, trisomy 18, and abdominal wall defects where the abdomen's open. And it gives somebody, again, just a readjusted age-related risk of having these things. Who do we offer testing to? We offer testing to people of advanced maternal age. So this is further testing, so beyond this, like amniocentesis or chorionic villus sampling. Advanced maternal age, that's greater than 35 years of age. A previous child or pregnancy with a birth defect, they would be offered further testing. Something suggestive on their screening test, so their a thick nuchal translucency, an abnormal blood test, or some type of family history of birth defect. The more advanced screening that we can do is chorionic villus sampling. It's done between 11 to 13 weeks of pregnancy, and put a little catheter in either through the cervix or through the abdominal wall and take a little bit of placenta basically from the pregnancy and then test it for chromosome defects or gene defects, and there's about a 1% miscarriage rate with that, so you could lose the pregnancy from having this test done. The test used to be done earlier, and they found that tests that were done at 10 weeks or earlier, for this, the babies could actually have limb deficiencies, like they could have part of their limb missing. So it's done later, a little bit later now, and you don't see that problem. People can also have amniocentesis done, and that's where we take a needle and we put it through the mom's abdominal wall and into the amniotic sac, and we take amniotic fluid out, and the amniotic fluid has living cells from the fetus in it, and then we test them. It takes a while to grow the cells in the lab, so you don't get this result back for a couple of weeks, usually 3 weeks, and we can look for chromosome and gene defects in that. And then everybody in California, all little babies are tested for diseases right after they're born. So when you're in the hospital, before you go home, when you're a little baby, they do a heel stick. They just stick their heel, they get blood from there, and they test. These are some of the things that they test for right here. And these are a lot of the tests that are actually available. Babies can be tested for in the first 2 days of life. And each state is different in which tests they do. And then we can do, this is sort of more what we do, is pre-implantation genetic screening. So we can actually test embryos for abnormalities before they're placed back into somebody's uterus. And the way that that's done is by, like I said, retrieving eggs, putting the eggs together with the sperm, growing eggs out to this day 3 stage, and then taking one of the blastomeres off of the embryo and testing it. Because when you look at embryos, it's really hard to tell which embryo is normal and which embryo is abnormal. And a very nice looking embryo can be genetically abnormal and vice versa. So we do pre-implantation genetic screening for people who have single gene defects, parents who carry a balanced translocation. Do you know what that is? Where they've, no? Okay, but some parents can actually have chromosomes stuck to each other, like you might have one of your chromosome 14 and one of your chromosome 21 that are stuck to each other. You're normal because you still have the normal number of chromosomes, but when you pass that off to your baby's getting an extra chromosome, or if you pass the one that was missing, they're getting one too few chromosomes. We do it for that. You can do genetic screening for advanced maternal age to see which embryos are normal. It could be used for repetitive IVF failures to see if, are they just not implanting because they're not normal, recurrent pregnancy losses, or to select a certain embryo that you want, boy, girl, somebody with disease, not disease. And then once we do this pre-implantation genetic screening, or once we pull the cell off, then we're going to look to see if it's normal or not in a couple of different ways. If we're looking for example, gender selection, we'll do FISH, about that, no? Well, it's just a type of a probe that attaches to chromosomes and it lights up. And so you can tell, do they have 2 X chromosomes? Do they have two chromosome 21s, or do they have 3 chromosome 21s? If they had 3, it would be Down syndrome. So it's a way of just looking at these markers to see how many chromosomes people have. They could do PCR, that, to look for specific single gene disorders. And then now what we're starting to do through this company that's called the Gene Security Network is we are starting to actually look at these blastomeres with microarrays and looking for all the chromosomes. So you could actually test an embryo for every chromosome, and you could also look at specific gene disorders at the same time. And these are some of the things that we can test for. On here, cystic fibrosis, Down syndrome, Fragile X syndrome. Okay, so why would people want to do PGS for single gene disorders? They may feel it's something safer than an elective termination. So if there's somebody who would terminate an abnormal pregnancy, it would be safer probably not to implant an abnormal pregnancy. For some couples, it's just more acceptable for them to, decide that this is where they're terminating their pregnancy, is right here before it happens. Sometimes when somebody has a genetic disorder, balanced translocation or things like that, sometimes their only options come down to this adoption using donor gametes and that type of thing. And it can give them another option that we actually can test them, and if we can find normal embryos that you could carry a pregnancy with your own eggs or sperm. This is the one? Okay, this is the, okay. So this is how we do pre-implantation genetic screening. This is how we biopsy the embryo. Turn what? So they're just taking off one of the blastomeres right there. So usually about 8 blastomeres at this stage where this is day 3. And then we'll just take one of them off. The other 7 will stay there. And then we'll test those by one of those methods that I just talked about. It takes some time to get the results back. So what we usually do is just let this embryo then grow for 2 more days. So it grows from a day 3 embryo to a blastocyst. On the day when it's a blastocyst, we have our results back. And we have a result back for every embryo. So we say this embryo is normal, this embryo has this embryo has this, and then we make a decision about what embryos to put back. This is basically what we just talked about, taking off one cell at an 8-cell stage. This is, again, this is the blastomere, and then this is the one that's going to be tested. Sometimes we test them in our lab for this, for example, this new with the microarrays, we're sending them out. So we're actually just fixing them, putting them in sending them off to this place to do it for us. There's different ways to test. The one that I talked about was using this fluorescence hybridization. So this is basically showing, these are little chromosomes that are fluorescing. The red ones will be chromosome 13. This is the X chromosome, so we know this is a girl. And at least for the ones that we're testing for, they have 2 21s, 2 18s, 2 13s, normal girl for what we're testing for. We're only testing for a few things in this case. For example, another example, this has 2 chromosome 21, so it doesn't have Down syndrome. It's a girl, it has 2 X's. We could use this for sex-linked diseases. There are sex-linked diseases like hemophilia, for example, that you'll mainly pass on to boys. So people with that in their family might decide they want to do this and just put in girls. or family balancing. That's another thing that we already talked about. Same thing with boys. Okay, so the question is, ethical question here, if you had one or more children of the same sex, let's say you had 2 girls, would you like to be able to choose the gender of your next child? Okay, so you split. So some people would say yes, they would like to know, and then half of you would just let it, whatever happens. Okay, yes?
So I have a question. When you have couples come in and you run all these tests, is there like a certain amount of tests you can have run? Like, could you specify what you wanted to be checked for during PGS? Or is there like an actual checklist that every single embryo goes through?
No, so that's a good question. Without this new technology that I'm telling you about, we were able to do, let's say we were just trying to look for chromosome disorders. We could look at either 5 chromosomes or 10 chromosomes. And they're the most commonly abnormal chromosomes. With the new, or you could look for a single gene defect. You could say, you know, we have Huntington's, we have cystic fibrosis, we have whatever, and we could test for that specific thing. Couldn't do the 2 together though. We could just do one or the other. With the new technology that's there, you can test for all the chromosomes, and you could test for this, this, and this gene disorder. And there's like 50 or 60 right now on their initial, on this company, on their initial screening test, like about 50 or 60 things that you could test for in an embryo.
So most of the time when you're implanting an embryo inside a woman, you know whether it's a boy or a girl, and do people
No,
just...
most people don't do PGS. Majority of people that I see do not test their embryos. They do IVF, they grow, we put them back.
But they do amniocentesis sometimes at 20 weeks still?
Yes, yes. And even people who do PGS, we recommend that they do all the prenatal screening that they would have done. It can be wrong. And that's happened, where people have thought that they've put in a baby that wasn't affected with cystic fibrosis, and they've had a baby that's had it. It's very rare that that would happen, but we always ask them to have their regular testing too. Yeah, and not a lot of people do PGS. Most people don't. Okay. So the difference between just prenatal diagnosis, for example, like amniocentesis versus PGS. For amniocentesis, you need about 100,000 cells to test. PGS, you need 1. It takes about 2 to 3 weeks to get results back. Here we have it back. Usually, I mean, we have it back for sure within 2 days, but it might get as soon as 6 to 10 hours. They're both very accurate. Pregnancies are covered to have amniocentesis done, and PGS costs about $5,000 to do. I've already really touched on this. You know, people who would benefit from it: abnormal chromosomes, gene disorders, balanced translocations, or maybe gender selection. And then these are kind of things that are coming up into the future, and they're happening. I mean, egg cryopreservation, so egg freezing, that is happening now. We do egg freezing. It's basically research protocol that you have to do it. It's considered to be a research-based technique. Eggs don't freeze as well as embryos. It just has to do with them being big. They've got a lot of fluid inside. They don't really thaw out as well. They get ice crystals inside of them. But we do have pregnancies from people who have frozen their eggs. So this is someone who doesn't have a partner, let's say, who doesn't want to have a pregnancy now but wants to save their eggs. And then what they can do later on is thaw out their eggs, put the eggs together with sperm, and have a pregnancy later. It takes a lot of eggs to have a pregnancy, actually, though. So it's just not, the technique's certainly not perfect at this point in time. It's not as good as embryo freezing. And then there's, you know, questions of, could we do this like cytoplasmic transfer maybe, where people would be able to use, you know, part of their material from the egg from like a young person and part of the material from themselves, so they could potentially have a pregnancy that still has their own genes inside. And then, oh, I don't even know if I want to go into that last one. That's just sort of very future. This is some information about egg freezing. There are places that do, you know, egg freezing, but like I said, it is research-based. I don't have a lot of people come to me that want to freeze their eggs, but I do have some people. It's usually recommended if people freeze their eggs that they're less than 35 years of age when they freeze them, because those eggs seem to do better. And that's it. Do you have questions at all? No.
I'm sorry, I just have one more question. Regarding whether or not, like, let's say a woman doesn't have healthy eggs, therefore she would maybe have her, she would find a donor, and that egg could be donated, and she could still have the child grow inside her.
Yes.
But let's say she doesn't have healthy eggs, and she gets the egg from someone else. Is there any way, can you successfully enucleate that egg that you got from the donor and put in your genetic material?
That's what we're talking about with the cytoplasmic transfer, is trying to do things like that.
Is it successful?
Not yet.
Okay.
Yeah.
Any questions from Davis?
No.
So let's say you have somebody who's 27 years old and isn't ready to have a pregnancy yet. What advice would you give them to sort of preserve their fertility?
I would say, 27's young still. It's important to think about, I think it's important to think about it though. You may not be ready to have a pregnancy now, but there are certain times where I think there's a lot of people who do get to a certain age and they think, oh, it's not the right time because I need to do this fellowship, and then I need to make some money to have my baby, and I need to do this and this. It's never really a good time. And I've changed my motto around to it's always a good time. It's always a good time. So if you think you really want to have a baby and you're in, let's say, a relationship with the person that you want to, and you're kind of waiting because, oh, let's wait till you get that job or you do this or that, it's probably just really good to have a baby because it gets harder and harder and harder. But I would just say it's just sort of like lifestyle things, just trying to live healthy, doing sort of things in moderation. If you do get to a certain age, it is probably a good idea to think about. If you're 37 and you're still I'm not really ready for this yet, it may be a good time to think about freezing embryos. 35, it would be an even better age to say, well, we want to do this later, but not right now. And to sort of have an option of having a healthier embryo that's available to you. Because like I said, a lot of people, majority of people that I see are just people coming in who are in their 40s, and it's really hard to have a pregnancy.
Elaine?
Are there any processes that you deny, the people that come to see you? You allow, some of them, to take it from their daughter or anything?
I think it's individual, and there's different people in our practice that do different things and believe different things. And it's really left up to each individual physician in our group to do what we want to do. And we might confer with each other and say, I don't know how I feel about this. If something kind of new comes up, what do you think? Or, and you might say to a couple, I've never done this before. I'm not really sure about this, and I need to talk to, the rest of my group and kind of get a consensus about this. And we do have people in our group, for example, there's something new within this past year, a law that's been passed in California that says that it's okay to treat, this was illegal before this year, you couldn't treat an HIV discordant couple, meaning that one person had HIV and one person didn't have HIV, and they wanted to have a baby through reproductive techniques. If it's much safer to have a baby with reproductive techniques, right, than to have sex if you have HIV. So these are people wanting to come in and say, we'd like to do an insemination or IVF because my husband has HIV and I don't. And that was actually illegal to do that in California until this year, until 2008. And then a law was passed that said that we can do it. And there are some practices and physicians who say, yeah, I would definitely do that. And there are other people who would say, I'm just thinking within my own group who say, no, I don't really feel comfortable doing that. So there's all sorts of different situations, and there's just different things that come up all the time. And I think you just have to feel, everybody feels differently. Some people really have specific guidelines about who they will treat. And I actually worked with a woman when I did my residency. They sent me out into the community to work with this lady who was a reproductive endocrinologist, and she would only treat heterosexual married couples. That was her thing. If you weren't, bye, gone. And and then there are other people that say, well, I will treat anybody who wants to have a pregnancy and they're not able to have pregnancy on their own. Yeah.
Any other questions?
Are there any cases that you talk about as kind of dinner conversation, or
Yes. Did you set her up for that, or?
No, but you can tell them.
Yeah. So I actually do. I have one interesting case. I have a lot of, there's a ton actually. But I do have one that was really, I've never seen this before, I've never seen it since, and I just didn't even know what to say. I saw a couple, they came in, she was 40 years old, he was about the same age, maybe 39. They'd been married for 3 months. And the very first thing it says on our questionnaire is, how long have you been trying to conceive? And it says months or years, and it says 0 months. And so I thought, okay, there must be something, maybe genetic history, some reason why they are just kind of coming here right away. Or maybe they just want a basic evaluation because she's 40 or something. So they came in and Sat down, and I said, okay, so I've noticed on here that you've been married for 3 months, yes. You haven't really tried to have a pregnancy. They said no. And I said, so tell me what why are you here? And they look at me, and I'm kind of looking at them, and they said, we want a sperm donor. And I said, okay. So I'm thinking, okay, he must know something. He doesn't have sperm. He's got balanced translocation, something. And I said, okay, so why do you want a sperm donor? And they look at me like, I don't know, I should know or something. And I'm like, okay. And she says, well, I mean, look at him. So that was just really bizarre. And he was just a normal looking guy. I mean, he wasn't like Brad Pitt or something, but he was a normal looking guy. And I just was like sort of speechless for a minute, and then we went on with the rest of our conversation. But people have odd requests sometimes. Yeah. So that's my dinner conversation. Yeah. 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 That's what I'm saying. They got married, and I don't know. I had a couple that came in. They were both from India. They wanted to use an egg donor. And most people choose an egg donor like them, that looks like them. That's what they're really looking for. And you actually see pictures of egg donors when you choose them. So most people kind of pick someone who looks like them and stuff. And they actually specifically wanted a blonde, blue-eyed egg donor. Mm-hmm. Yeah. I mean, and that's the only time I've seen that, because most people, their egg donors come in, and I know they're egg donors and I know them, but they don't know each other. They never meet each other. So I'm kind of like the only person who sees both of them. And it's really amazing how egg donors and recipients are just, most of the time, they're great matches. Like they kind of look like they could have been their sister, like their younger sister. Yeah, but this couple they just wanted someone who looked really, really very different from them. Mm-hmm. So there's all sorts of interesting things.
Are there any other questions? So why don't we end this on a little note. That is that you didn't discuss one cause of infertility.
What?
Not doing it in the right place.
Well, that Daisy can tell you about that.
So she left out that there was one cause of infertility, which is not doing it in the right place.
Some people,
and when Daisy took this class, she raised her hand and she said, you mean you have to do it in a specific room in the house? That's the truth. In any case, with that as a wonderful note, let's give a big round of applause for Dr. Evans for a wonderful presentation. Thank you so much.